Good morning, and thank you to Dr. Schwartz for the introduction. Like Dr. Schwartz said, the title of my talk is Only the Necessary Things. And this is a quote that comes from the ancient Greco-Roman physician Archibius, who lived around 2,000 years ago. And you know, in starting this talk, I was very grateful in thinking about it, to think about what Dr. Feinberg said yesterday. And I'm going to quote him here: "We have to be very mindful of history going forward," is what he said. So I'm very grateful to him for sharing that wisdom with the group yesterday. And I'll reference that quote as we move forward and talk a little bit more about Archibius. He said that students shouldn't bother to learn about theoretical problems related to the art of medicine. And instead, he said that students should learn the names of the diseases, and then that students' education should be limited to these necessary things alone. And his objection isn't new, and it's not non-existent in today's world. Witness the dramatic restructuring of the medical curricula at Harvard Medical School and at Vanderbilt in the last 2 or 3 years. And the history of schools of medical thought and of the discussion of theory in medical education is not the subject of my talk, and I'll dispense with mentioning the plurality of views of medical education in ancient Greco-Roman society. But I'll mention that these questions of epistemology, that is, of disease classification and issues of causality, loom very large in our sources. And my contention, which I'll hope to support as best I can in the next 11 minutes or so, is that these questions of disease classification and etiology were predicated upon the burden of disease that these physicians observed. Archibius' statement that students should learn the names of the diseases and then only the necessary things is actually deceptively objective. Names themselves are categories. They're collections of symptoms that observant physicians group together based on shared characteristics for the purpose of diagnosis and treatment. And to illustrate this point, we'll just talk a little bit about terms for cancer. This is one of the earliest references to something that we would call cancer from the ancient world, a karkinos, and this comes from the aphorisms of the Hippocratic corpus. It was called a karkinos, or a crab, we think, because of its hard texture and potentially from associated projections. And we can see from this quote, the Greek is above and the translation's below, and I've highlighted the relevant words in each section. We can see from this quote that this phenomenon is associated with a certain measure of intractability. And if we look now at this quote, we can see that there's a distinction between a karkinos, karkinoi in plural, and a fumata, plural, for swellings. And the fumata seem to be linked to children, and the karkinoi seem to be linked to older people. But there's a certain elision in this categorization, and that elision becomes even more pronounced when we translate this into English. If we move ahead into the Latin sources, this is Celsus, from whom we get the famous tetrad rubor, calor, dolor, tumor. He's writing about 500 years after the Hippocratic authors were writing. And he mentions tumor in what seems like a general catch-all term for swelling. And so we start to see this shift of categorization and of labeling. And this persists even today. So for Celsus, tumor was its own single individual categorization. What do we mean today when we say tumor? Tumor, in the Latin sense, means swelling. We can use it to apply to an area of indurated swelling, maybe a loculated abscess that's caused by a bacterial infection. But we also use it in the sense of a neoplastic process. And I've put a definition from Merriam-Webster, which is a lay definition, which is how many people understand this word. I've put that up here. And we also define tumor by biomolecular markers, by immunofluorescence or various other tests. And what I really like about the image that I put up here, we define tumor by image, is that this shows a cystic pancreatic tumor. So here's a tumor which has elements that are described by these terms in the Hippocratic text. So it's cystic. But at the same time, we would consider it a tumor, which somehow also has implications of being solid. So there's this fluidity in terms of how we think about, how we label, how we categorize disease. And for a similar example from the modern period, think about cervical cancer. The disease name itself is a little bit deceptive in that it does refer to a neoplastic process, but it does have a root cause that in some instances is infectious. So what does this have to do with evolutionary medicine? First, let's talk a little bit about epidemiological transitions. And I put a summary here on this slide of the characteristics of the first epidemiological transition, generally, broadly speaking, largely infectious, and the second epidemiological transition, which has been associated with diseases that are considered more degenerative or chronic. And evolutionary medicine has helped us to see and to track the trajectory of human history in terms of these epidemiological transitions. And so now, a way to think about this could be to look at this graph from the WHO. So the blue lines represent data from 2012, and the purple lines represent data from 2000. And if you look at the chronic conditions, ischemic heart disease, stroke, tracheal, bronchial, lung cancers, diabetes, those blue lines are longer than the purple lines. So we're seeing this increase in chronic degenerative disease. Now if you look at lower respiratory infections, fourth down from the top, diarrheal disease, tuberculosis, HIV, which wasn't as much of an issue in the ancient world. But if you look at these, the purple line has gotten shorter. The blue line in relation to the purple line has decreased over time. So we're seeing, even in the last 12 years, 14 years, a decrease in these infectious disease rates and an increase in the rates associated with acute and chronic disease. And alongside shifts in how we think about disease and how we classify disease, we're observing the resurgence of treatment-resistant and or highly virulent infectious conditions, XDR, TB, Ebola, H1N1 influenza. And at the same time as all this, recent research has indicated an unexpected decrease in the virulence of HIV in populations in which the disease can be considered by some metrics endemic. And evolutionary medicine has been essential in helping us to identify these shifts and to characterize them more precisely. Medical treatment and theories of disease have been and continue to be related to the observability of a symptom, a sign, or more recently, a lab result or an image. And so how do we put all this together? Dr. Schwartz mentioned these disparate elements, seemingly disparate elements of what I do. What is one way we can put all of this together? And I'll offer that one way we might do that is through an example. And I'll offer the example of malaria. And studies in evolutionary medicine and in paleopathology, while the data aren't perfect, have indicated a prevalence rate of malaria in the ancient Greco-Roman world and in the ancient Egyptian world of around 50%. And we understand the evolution of genes related to G6PD deficiency, the thalassemias, and sickle cell to be intimately related to this process in a time in which infectious conditions like malaria plagued much of humanity. The ready observability of this condition of malaria, for example, with its cyclical pattern of fevers, really indelibly shaped a theory of illness that would persist for 1,500 years. And this is involving the idea of a crisis or a critical point at which the patient experiences or evinces a symptom or a sign, generally a fever, which predicts the outcome of the illness and should guide the treatment of the illness. And this word is important because in an ancient Greek context, it's a word used in law courts for a judge. It's a decision point. It's a point at which an action is taken. And here it's actually used as a verb. So curiously, this is something the disease does. It puts the patient and the physician in this position in which a decision has to be made. And so this happened specifically in the case of cyclical fevers associated with malaria. And so many physicians thought that this was how one should understand a disease process. Physicians thought about pathological conditions in this epistemological framework of searching for and identifying this crisis or critical moment based on these infectious acute conditions so prevalent in this time period. So physicians searched for evidence of crises, they sought to predict crises, and then they diagnosed, prognosed, and treated based on these crises. Classification schemes and etiological explanations for nearly all types of pathologies, trauma was an exception to this, were predicated on symptoms of acute infectious disease, especially malaria. And in the West, this remained largely the case until the Renaissance. While there are many differences between the medical treatments of Greco-Roman antiquity and those of the modern period, I really think that few stand out in sharper relief than those related to surgery. This is a long text, but I've highlighted the important points, which is essentially that surgery was very dangerous. Though evidence of successful life-saving amputations can be found in both paleopathological and text-based evidence, surgery was a last resort and often led to death, or at the very least, greater morbidity than was present at the outset of the problem. Witnessing the discovery of anesthetics and antimicrobials, the 20th century saw stunning surgical successes, from appendectomies to cardiac catheterizations. The internal afflictions that in the past led to patients' deaths have since been eradicated to an extent, in large part because of the possibilities afforded by surgical intervention. We now outlive many of these acute conditions that in the past caused all sorts of problems. And these acute conditions shaped medical practice in the past. And if we're leaping forward about 2,000 years into the 20th century, we can see how medical schools have shifted their focus from the treatment of acute disease to the treatment of chronic disease. Today in the United States, we speak much about the utility of the primary care model. And the aforementioned revised curricula of Vanderbilt and Harvard place more emphasis on longitudinal training experiences, including extensive primary care training, that facilitate relationship building with senior physicians and their patients. This is in marked contrast to the self-contained rotation units that characterized much of medical education since the publication of the Flexner Report, which Dr. Schwartz mentioned yesterday, in 1910. Why focus on the long term and on primary care? Public health research, as we all know, has indicated that healthcare systems with this strong primary care focus help to alleviate patient suffering, societal disease burden, and the overall cost associated with chronic disease. We're restructuring our healthcare system and the way in which we educate medical students to take into account these shifts in the burden of disease, alongside a focus on global health as a way of addressing the continued disparity, the continued existence of these acute infectious conditions in part of the world that lack the infrastructure to help eradicate these conditions. So how do we then, in conclusion, think about and prepare medical students for these shifts in burden of disease? And to what extent can evolutionary medicine help us in this endeavor? I would venture to suggest that evolutionary medicine can, to an extent, help us see into the future. So we have the crisis of the past, which was characterized by observation diagnosis, a moment of intervention, and acute, often infectious conditions. And now we have the crises of today and tomorrow, which have all of these elements, plus the added element of this increase in chronic disease. Consider the recent discoveries related to the virulence of HIV, to which I referred earlier. At the level of viral and cellular evolution, we're observing a decrease in the replicative abilities of the virus in response to medical treatments provided to large populations over the course of decades. Evolutionary medicine observes, quantifies, contextualizes, and explains this and related phenomena. Medical education has and continues to evolve as disease changes, and acknowledgement of the field of evolutionary medicine within the medical curriculum will permit medical students and educators to leverage the power and interdisciplinary nature of this field for the benefit of patients. As a field, evolutionary medicine lies at the intersection of medicine, history, anthropology, archaeology, literature, epidemiology, biology, and countless other disciplines, and at the intersection of the past, present, and future. And I'll conclude by mentioning one of my favorite quotes from the Hippocratic Corpus. This is the first of the Hippocratic aphorisms, or guiding sayings on the treatment of disease. And it says, "Life is short, the art long, opportunity fleeting, experiment treacherous, and judgment difficult." Crisis, judgment is difficult. And I really can think of no better way to appreciate the duration and persistence of the art than with an evolutionary perspective. Thank you.